Okay. So hi everyone, and welcome to the Cardiff Student Psychiatry Society session on neurodevelopmental disorders. So just to start us off, a couple of content warnings. So in this session, we will include discussions around neurodevelopmental disorders, including ADHD and ASD. So if you need any help regarding any of these topics, here are a list of sources you may wish to contact for support. Next, we've got our pre-session questionnaire. So if you are able to, you can fill that out. So the learning outcomes of this session are to discuss the definition of a neurodevelopmental disorder, and we'll be focusing primarily on ADHD. So that's attention deficit hyperactivity disorder, and ASD. So that's autism spectrum disorder, how to recognize the features of these conditions, and recapping the approach to managing these conditions and what support is actually available. Okay, so what are neurodevelopmental disorders? What is meant by this? So by definition, a neurodevelopmental disorder refers to a group of conditions that arise due to central nervous system dysfunction and can manifest in a wide variety of ways, including neuropsychiatric problems, impaired motor function, impaired verbal or non-verbal communication, and issues with learning. So attention deficit hyperactivity disorder. So the definition for which is a persistent pattern of inattention and or hyperactivity impulsivity that interferes with functioning or development. And it can be split into 3 different types. And this depends on how prominent each of the traits are. So what are the traits? We'll be covering this in the next slide. So there are 3 main traits of ADHD, which include the following. So you've got inattention, hyperactivity, and impulsivity. And below each are some examples of how they may manifest. So with attention, individuals may wander off task, give up on tasks, and get distracted easily. With hyperactivity, this may manifest as excessive fidgeting and talkativeness in children, and restlessness in adults. And in impulsivity, this may manifest as doing things without having thought of the consequences first, and things like interrupting others mid-conversation. So with these symptoms, it's really important to note that many of the symptoms of ADHD are common with most children. It's when these symptoms are exaggerated compared to others, and when symptoms begin affecting the child in school and social settings, that we begin to think of ADHD as a possible diagnosis. Okay. So the global prevalence of ADHD in children is estimated to be around 5%. It's more commonly diagnosed in boys than girls, and there is a strong evidence that there is an inherited component. This sex difference may be due to the fact that boys present more often with disruptive behavior that prompts referral. So going by the DSM-5 criteria, if there are at least 6 or 5 in adults, symptoms of inattention and hyperactivity impulsivity, ADHD is likely, it's probable. However, the symptoms must present before the age of 12 with a persistent pattern for at least 6 months, and should be present in 2 or more environmental settings, such as in the house, in the classroom, for adults at work. And there should be evidence that these symptoms are interfering with or reducing the individual's social, academic, and daily functioning. And finally, for diagnosis, it is important to exclude the symptoms as being better explained by another mental disorder, such as schizophrenia and anxiety or personality disorders. ADHD can be classified as mild, moderate, or severe, depending on the number of symptoms and how much they impair day-to-day functioning of the individual. So this is a slide a bit about the assessment of ADHD. So in children and adolescents with suspected ADHD, it's important to assess the social and educational impact of their symptoms. And in adults, it's important to assess these too, and also the impact their occupation may have on their functioning. It's important to refer adults without a prior diagnosis of childhood ADHD for assessment by mental health specialist. So this slide is covering the management approach that should be taken. So management should be initiated and coordinated by specialists, and it should be individualized, taking into account factors like the person's age and the degree of functional impairment. So children and adolescents with ADHD may be offered group or individual interventions and support groups, which aim to share coping strategies and provide adequate support for them. In schools, there may be a SENCO. So this stands for a Special Educational Needs Coordinator, and their role is to assess, plan, and monitor the progress of children in school, and ensure that they're being supported by their peers, by their teachers, by everyone, basically. If there is still persistent significant impairment despite the above interventions, medications may then be considered at this point. So methylphenidate is the first line pharmacological treatment of ADHD, and can only be used in individuals who are more than 5 years of age. And there's other alternatives that you might have heard of, which include things like lisdexamfetamine, and atomoxetine. Similarly, in adults, you can prescribe the methylphenidate to help with symptoms of ADHD, and CBT in combination with this medication may be considered for adults with ADHD who have benefited from the medication but still are having problems and still have a degree of impairment. So now a bit about methylphenidate itself and how it works. So it's a central nervous system stimulant, and what it does, it actually inhibits the reuptake of dopamine and noradrenaline. So by doing this, it's actually increasing the amount of these neurotransmitters in the synaptic cleft. And this is thought to help with the symptoms of inattention, hyperactivity, and impulsivity, and increases behavior alertness so they can sort of control their behaviors better. So it is potentially cardiotoxic and contraindicated in several cardiovascular conditions like arrhythmias and cardiomyopathy. So it's really important to do a baseline ECG before commencing treatment. It may also suppress appetite and cause growth impairment in children. So weight and height should be monitored ideally every 6 months. So that's important stuff about methylphenidate. Now on to some SBAs. So I'll read the first one out. So a father brings his 7-year-old son into the GP surgery. He's not doing well at school and he thinks he may have ADHD. So which one of the following features is not consistent with a diagnosis of ADHD? So is it A, extreme restlessness, B, impulsiveness, C, poor concentration, D, ritualistic behavior, or E, uncontrolled activity? So I'll go if anyone knows the answer yet. So it is D. So I wrote this question in a way so that it highlights sort of the important point of actually reading the question. So it's asking for a feature that isn't consistent with ADHD. So as you correctly identified, yeah, D is not consistent with a diagnosis of ADHD or a trait of ADHD. So yeah, moving on to the next SBA. A 10-year-old boy is diagnosed as having attention deficit hyperactivity disorder and is started on methylphenidate. So which one of the following investigations is important to perform before starting this medication? So is it A, an ECG, B, blood glucose, C, liver function tests, D, renal function tests, or E, urinalysis? So does anyone? Yeah, so it's A. Yeah, so ECG, because methylphenidate is cardiotoxic, and it's contraindicated in certain cardiovascular conditions like we covered previously. So it's really important to get a baseline ECG before commencing this treatment. correct? Okay, now moving on to autism spectrum disorder. So autism spectrum disorder is an umbrella term used to describe lifelong neurodevelopmental disorders that affect social interaction, communication, and behavior. And the core features include things like persistent difficulties in social interaction and communication, the presence of stereotypic behaviors such as rigid and repetitive behaviors, and things like being resistant to change or having restricted interests. It's important to note that the way in which ASD manifests in individuals differs at different stages of life. So the way that it manifests can differ because you have different interventions that are being used, and you may have coexisting conditions that may alter and impact the way that it'll manifest. So the features of ASD may range from mild to severe. So there are many risk factors for ASD, such as having a sibling with ASD, having a learning disability or ADHD, as well as disorders like Down syndrome, Fragile X syndrome, muscular dystrophy, neurofibromatosis, and tuberous sclerosis. So these are sort of the known risk factors of ASD. So ASD is one of the most common childhood onset neurodevelopmental disorders. The estimated global prevalence in children is around 1 in 100, and it's 3 to 4 times more. Boys are 3 to 4 times more affected by ASD than girls, but this varies across the spectrum. And then the diagnostic criteria for ASD is stated in the DSM-5 again. And this includes persistent deficits in social communication and social interaction across multiple contexts, again, restricted repetitive behaviors, interests or activities. And similarly to ADHD, symptoms must be present in the early developmental period and cause significant impairment in functioning. And again, like ADHD, it's important to ensure that these symptoms are not attributed to by any other disorder. So separate disorders, things like intellectual disability and global developmental delay. So this slide is quite comprehensive, but basically it just covers features and behaviors that may be suggestive of ASD. And it splits them into things that you might observe in preschool children versus older children, such as those in primary and secondary school. So you can have a read of this in your own time, as there's quite a few to go over. But just to name a few examples: language delay or regression, which is seen in preschool children, and reduced or absent ideas and imagination in older children. So again, assessment in adults is quite comprehensive as well, and the approach depends on whether the individual has moderate to severe learning disability. So for adults without this, tools such as the autism spectrum quotient may be helpful in identifying those who should be referred for further assessment. And I believe it's a score of more than 6 that would prompt this. And then for adults with moderate to severe learning disabilities, if they demonstrate 2 or more of the features listed below, such as difficulties in social interaction, marked repetitive activities, then they may be referred for further assessment. So it's important that once ASD has been diagnosed, children, adolescents, and adults with ASD and their carers are offered the relevant information, services, referrals, and practical support. It's important to make them aware of the benefits that they're entitled to and the support available. And ideally, you should take an MDT approach with this, so consulting things like SALT, so speech and language therapy, psychologists, child psychiatrists, pediatricians to give their input in to give their input and support in that individual's sort of care. And then regular reviews of individuals with ASD in primary care are sort of decided on by case basis. And then in terms of medical management, it doesn't really play a huge role in ASD, but medications may be useful in things like managing problems with sleep or challenging behaviors if they are present in the individual. So yeah, that was ASD revision, and this is an SBA that I have, so I'll read it out. A 4-year-old boy has been referred for further assessment for possible ASD. Which of these is not a recognized risk factor for ASD? So I'll give you some time to have a look. So is it A, Addison's disease, B, ADHD, C, Down syndrome, D, having a sibling with ASD, or E, muscular dystrophy? So which of these is not a recognized risk factor for ASD? There's quite a few risk factors, so I can see if you haven't remembered it. That's fine. So E is actually a recognized risk factor for ASD, but it's not the most recognized risk factor. So that was quite a difficult one. So it's actually A, Addison's disease, which isn't. ADHD, Down syndrome, and having a sibling with ASD are all risk factors for ASD. So yeah. So thank you for coming and thank you for listening. It wasn't I didn't expect it for it to be that long anyway, because it's quite a short summary on the two conditions, ADHD and ASD. And then in terms of getting the slides, if you are able to fill out the post-session feedback, then you can get the slides. Otherwise, you can access this PowerPoint and this presentation on YouTube. I think the account is called Cardiff Student Psychiatric Society. And if you have any questions, I'm happy to stay on for a couple of minutes. Otherwise, you can email me. My email's just below there, elapanecp@cardiff.ac.uk. So yeah, I'll probably just stay on for a few minutes. It's all right, thank you.